women, I think, are often hear about breast cancers in terms that might be oversimplified, but I think there's a lot of concern and confusion about this. And what I'm trying to get at is there is this notion that we're all hearing that within the big world of breast cancers, there are many that are treatable, and you can deal with them and live to tell the tale. But that within them, there is also a smaller population that tend to be what are called very aggressive. And the question that patients, that I hear all the time from people who are being treated, writing to us, are, well, how do they know at the beginning, or do they know whether a particular tumor is aggressive or is more or less likely to become aggressive? Maybe tumors change as they go along. Can they start out looking non-aggressive and then have a mutation that makes them turn bad? But this is something I think patients are really struggling with. I rode in this morning on the train with someone who started out with a tumor that wasn't looking so aggressive, and things have changed, and she's having her breasts removed next week.
So over the past decade, there have been a number of genetic tests developed that can sort of measure that inherent aggressiveness of the tumors, and these tests are used to predict your prognosis, right?
And are they being widely used?
Much more so.
They are gaining much more usage, and more of these are being developed, and the existing ones are being improved. And as we learn more about the genetics of the cancers, I think they'll continue to be improved.
Is this the kind of thing that involves a chip?
Some of the early ones used a chip or a DNA microarray, but now they're moving to many different technologies. But basically, they measure the activity or the presence of certain genes, and now we're starting to move into assays that will detect specific mutations, which can tell you both something about your prognosis and, importantly, also tell you what targeted therapy that you might be able to give to this patient.
And what proportion of patients are getting access to this kind of sorting out of the tumors now when women get a diagnosis?
Well,
do you need to be at a big cancer center for this? Are community hospitals doing this?
No, I would hope that every patient in the United States and across the world, frankly, would have access to the most basic testing, estrogen receptor, progesterone receptor, and HER2 testing. And certainly in the United States, I think that is the case. I think that some of these other multi-gene assays are also out there routinely in clinical practice. And actually, some of them have been tested in very large clinical trials where many patients and doctors in our country and around the world have stepped up to try and figure out exactly how they should be used. So they're out there. I think there's no question about that.
So I think I think one of the important things to think about is that it is hard to cure metastatic disease, and so one of the things that we can do, if we can identify people who have aggressive tumors up front, I actually and many think that the opportunity is to try and introduce drugs earlier on. So when people are first diagnosed, so a lot of people have used the setting of people who come in with larger tumors or who have higher grade or people who we think are at risk for early recurrence. And we're getting increasingly sophisticated at figuring out how to predict those patients and to come up with clinical trials to help us understand whether the drugs are working up front. It turns out that the order of therapy doesn't really make a difference in your outcome. But if you have a large tumor...
What do you mean by the order of therapy? What are you talking about?
The standard thing is for everyone to come in and have surgery first. There's something appealing about that. It sort of makes sense. So we're going to take it out and make it go away. But I can tell you as a surgeon that if someone is at risk for dying of their disease because the tumor is likely to spread and we have to really get rid of the cells everywhere in the body, I am not going to make a difference by operating on that person. Where we're going to make a difference is understanding whether we've got the treatment right. So you can just change the order of therapy and start with what we call the systemic therapy or the chemotherapy. And in that window, we learn a lot.
Is there evidence that it's okay to do that?
There is plenty of evidence. There are 6 randomized trials, and there are many, many trials now that show that. So what we also find, and actually there's a large clinic, there are many trials in the cooperative setting. I run a big trial program called the I-SPY trial, where we routinely we actually molecularly characterize those tumors right up front, and we determine if they really have the aggressive tumors, and we actually are trying to learn which. We take standard therapy plus or minus a number of new agents. And the whole idea is to try and understand upfront, as early as possible, which of these agents are going to work for which kinds of tumor. That's the point. That's, I think, it's a critical opportunity to make progress.
All right, so let me just give this back and make sure this is clear, at least to me. So what you're saying is, if you go in and you remove the tumor first, and then you're giving the chemo, it will take longer or be harder to tell if the drug is really working. But if you've got the tumor there and you give the drug and the tumor starts shrinking, then you know you've got something that at least is having some effect on that tumor? Is that what the point of this is, of switching the order for a study?
That's correct. And I think that we do know in the women who are at risk for early recurrence, so these fast-growing tumors, these are the tumors for which we know that chemotherapy is effective, very effective for many women, but probably, there are about a third of women, their tumors go away altogether. But there's plenty of room for improvement. And for those particular women, trying to figure out how to target their tumors specifically with new agents can really help us learn for which tumors, which drugs are going to work, and to qualify these or figure out more quickly and get them FDA approved much more quickly without having to go through a long 10-year process, starting the metastatic setting and then going back to the adjuvant setting.
Dr. Sledge, you want to say something?
Yeah, I think actually what's a bit safer to say is that we know that giving systemic therapy before surgery gives you equivalent results to giving you systemic therapy after surgery. Right. That's what the clinical trials show. What Dr. Esserman is discussing is in the investigational approach to looking for new drugs for breast cancer, which is something a little bit different.
Well, it's a combination.
Right? Yeah, and quite valuable, but I wouldn't want the audience to come away with the idea that we can routinely tell you exactly which drug you should get based upon preoperative therapy.
So what you're talking about is a study that is looking to develop new drugs. So you've got a bunch of experimental candidates.
Right, but I would also say that even if you're not in a study, there are a lot of other advantages to thinking about doing the systemic therapy first. If you have a large tumor, not infrequently, you can shrink it sufficiently to have breast conservation. You may not need to have a mastectomy. If your tumor goes away, you may not need to have radiation. So there's lots of ways in which you can tailor the rest of your therapy on the basis of how your tumor responds.
I don't know that I would say that you could tell a woman she didn't need radiation based upon response to preoperative therapy. There's certainly no data to support that.
But I think what you can George, I think what I'm saying is that you can tailor the therapy. So if the tumor shrinks enough to have breast conservation, you would have radiation. If that woman chose to have a mastectomy, she may not need radiation. So and what I'm saying is that there's opportunity to continue to tailor therapy based on the response to therapy. And we know that's
Dr. Rosen, you wanted to
Yeah, I guess I
make a
wanted
comment.
to say some things to the audience rather than yell at George. Two things that I want to make clear, and it's probably clear to most of you, but I think it's important you know this. When we say poor prognosis or aggressive, or good prognosis and indolent and likely to be cured, those are probabilities, they're not certainties. There are patients with aggressive features, you treat them, they will be cured. Unfortunately, the reverse is true as well. That's the first point. The second point is this is not fixed, it's a moving target. When we discovered HER2 breast cancer was a poor prognosis, aggressive disease. Then Herceptin and now other HER2 inhibitors are available, and we know how to give it in an adjuvant fashion, as Laura suggested is the best way to do it. Now it's not a poor prognosis marker. It's a relatively good prognosis marker compared to others. So as we learn things and learn what makes the tumor poor prognosis, we can develop drugs against the features that are causing that and shift you from poor to good prognosis if you have that tumor.